everyone. Welcome to the later years. Like, this is definitely the biggest crowd. Congratulations. You've made it through the hard stuff and you're ready for the next hard stuff, menopause. Okay. All right. I have like some slides just so that I had some content for y'all. But I want to make sure there's plenty of like Q&A type of stuff. So we can do questions at the end. We could do questions in the middle as we go through different topics, but I'll kind of like go through some topics. And if you have a burning question, just raise your hand and we'll kind of talk through. That's how we've done it in the last couple of sessions, and it worked out pretty well because we had just a variety of questions about different things. Okay. So rock and roll. All right. Perimenopause. This can be, okay, so there's perimenopause is the time leading up to menopause. Menopause is when your periods stop, and then postmenopause is the time after. So are you filming me? Oh.
No.
I was like, should I post?
You can post later.
Yeah. So anyways, perimenopause, it's crazy. It's a wild ride. You're on a roller coaster, and this ride it can be a long time. It can be like up to 10 years leading up to your menopause, which is the stop in your period. These changes that you're feeling are because of a major drop in estrogen that happens as you get closer to the menopause time period. Keep in mind, during this time, you can still get pregnant. Where's Mama at? There she is. Evidence that at age 45, almost 46, you can still get pregnant, have a baby. So, yeah, it'll be the biggest blessing of your life, but it also might be the biggest surprise. So just keep in mind that you can still get pregnant in this perimenopausal time. All right. It is very unpredictable. And by unpredictable, I mean your periods are unpredictable. Your mood's unpredictable. You are unpredictable. Your husband might not recognize you anymore because you're a whole different person. And it's unpredictable, meaning everybody is very, very different. What Megan goes through is going to be very different from what Chelsea goes through. So you'll sit and talk with your girlfriends and just have a good laugh about it and just know you're not going to be all the same. Everyone is just very, very different. Some things that can help, because the cycles that are very crazy, which impacts, your mood, your bleeding, everything, is it is still okay to be on hormonal birth control during this time, or like either pills by mouth or an intrauterine device, which is the little T that we put in the uterus. It can help kind of regulate the cycles, regulate the mood, and kind of troubleshoot some of the problems and the symptoms that people have during this window of time. So just because you're kind of in your 40s doesn't mean that it's not okay to be on birth control to help with some of those symptoms. People always come to me and say, can you test my hormones? Which is very common. I mean, this past year, I was like, okay, I'm going to get my thyroid tested. Please let it be abnormal, and that'll be the reason I'm gaining all this weight. And it was normal. So I've been myself where I'm like, please check my hormones because I want something to be wrong that you can fix and make me skinny. But I get asked this all the time. Can you check my hormones? And it's not super helpful to check the hormones just because there's surges, there's up and downs. We can see kind of an overall trend of, okay, your estrogen is lower. Okay, your the FSH, which is the stimulating hormone of your ovaries, that's really, really high, meaning it's working. So your ovaries are just not functioning very well. There's some overall trends we can see, but in this window of time, the hormones are kind of all over the place. So it could be that you have your hormones tested and there's not like a clear answer of, am I in menopause? Am I not? Welcome, Kyle, to the show. But those tests might not be particularly helpful. Sarah.
Well, I was wondering with the hormone level testing, because like we have our cycle, there's first week, second week, all those things. Like, is there, if you were going to get your hormones tested, is there a particular time, like after I had my period, and then like I get a fresh batch, so to say?
That's a good question. Depending on what they're looking for, they might tell you, okay, go in, 5 days after your period, or go in. They'll tell you maybe when. And when we get like results back of hormones, it says like, okay, this is the normal range during the follicular phase, or this is the normal. So it tells us like normal ranges based on those phases, but those ranges are pretty like drastic too. So depending on what they're looking for, they might say, okay, this is the best time for you to take, I want you to go on day 3 of your cycle for this test, for example. Like there are certain tests we do time with the cycle, and just depending on what it is. Okay. Yeah, they'll tell you when to go in for that. Okay, so yeah.
What years does this start?
Okay, good question. The average age of menopause, which is the cessation of your period, is about age 52, and that's average. So some people might stop having their periods at 48, and some people might stop at 54. So if you're talking about the 8 to 10 year window before that, then this can start in your early 40s. Some people have like premature menopause, so this can start in the late 30s. It's tragic, but some people end up going through menopause, even earlier, which is like significantly premature menopause. And so it's abnormal for you to be going through these things if you're in your 20s or early 30s, but changes can start, I would say, late 30s and 40s even. And these symptoms are like a vast array of symptoms, none of which are pleasant. So you're tired, you've got irregular periods, loss of libido, sleep disturbances, emotional issues, which are all over the place. So nothing super fun for you or your family, but it happens. Gabby.
So when do you know that it's your hormones versus life is just busy and I'm tired and I didn't exercise today, so I don't have energy. Or is it
Okay.
always just your body? I don't know.
I would say most of the time it's your body and those hormones, because of the normal fluctuation of how they have those hormones contribute to you feeling like that. But most of the time it is probably a normal course of what you're going through. And But there are times when your thyroid is hypoactive and you just like have been living with that for years and not realizing it. So I mean, so that being said, it's helpful. That's why like annual exams are super important and helpful, because you can kind of check in at that yearly mark and be like, okay, well, I've been feeling like really like this. And so maybe you do want to get things checked periodically just to be on the safe side and make sure you're not. But that being said, if it's like menopausal hormonal related issues, there's not really a fix for that. It's kind of a waiting game. I mean, there's some treating the symptoms kind of situation, but it's a phase of life you have to go through. But like if, for example, if your thyroid is not functioning properly, that's something that's fixable and things like that. So it's hard. You don't really know when it's like, okay, this is life. I'm 46, so I'm going to be tired and a little bit chubbier, and that's me. But yeah,
And you can also be anemic.
100%. That's a good point. So usually in preventative care, when you go in our age group of going in for your pelvic exam and all that stuff, usually lab work should be probably a part of it. And that not only do they check your cholesterol and things like that, but they will check some of your hormones, including your thyroid, and they will check a blood count, because you're right, anemia can be a part of it. And when your periods are very irregular during this phase of life, we tend to see some issues with anemia for sure, which is low blood count. All right, on to the next. You ready? Okay, so menopause is when you have not had your period for a full year. That's what we consider, that's like the definition of menopause. Like I said, that's usually around age 52. And this part in time, the symptoms are still there of the other stuff, but then we start seeing more, because the estrogen level has dropped significantly. We see more issues with like vaginal dryness, even more weight changes. We start seeing hair and skin changes, like hair falling out, weakening nails, thinner skin, and pelvic floor issues become even more prominent now. And that's like leaking. Oh, fun. That's like leaking urine, kind of a drop in your bladder, drop in your uterus, things like that. We might talk a little bit about that if y'all have questions, but these are more of the symptoms we see during this window of time. Shall see.
Is it like genetic, the age that you're, yes?
We see a lot of, correlation, like
Okay.
your mom, like when she
My
would
mom was 43. She was super early, and my sister's 40, and she's already starting to like see a lot.
Okay,
Of
there are a lot
I'm
of,
still young too.
yes,
That's why I'm
there are a lot of genetic like predispositions, I guess you could say, to like age of menopause, just like there are in like childbirth and some of these other things. Like there's not like a direct gene that causes that, but for some reason we see like kind of. So if your mom had went through menopause a little bit younger, you might as well. 43, that's pretty young. Yeah, Karen.
How does the hysterectomy affect this? Do you go directly to menopause? Go straight to?
Good question. I might have a slide on hysterectomy, but I'll tell you, hysterectomy, there are a bunch of different types. So, Megan, do you want to be my example up here? So, a hysterectomy is technically the removal of the uterus. Some people use the word partial hysterectomy, What in the medical world we refer to that is removing the uterus and leaving the cervix behind, which is the opening or the mouth of the uterus. That's what I would refer to as a partial hysterectomy. But there are people that use that word referring to the ovaries. So when we talk about a hysterectomy, that's taking out the uterus, which has nothing to do with the hormones. And we say with or without oophorectomy, which is removing the ovaries. So if you have a hysterectomy, that's usually because of some sort of bleeding problems or pain, endometriosis, fibroids. The uterus is causing some kind of problem. So we remove the uterus. If you're young and you have that done, we usually leave the ovaries in place because they still make the estrogen hormone that is super important for life. And they still have some good value. And so you can have a hysterectomy and still have your ovaries totally intact. Sometimes you go through this little where they take a hit for a couple months and you just like, they're a little stunned because there was surgery nearby and some of the blood flow might have been disrupted temporarily, but they usually will just like perk right back up and just kind of steadily decline like a normal natural menopause. But if people have a hysterectomy where they take the ovaries, it is an abrupt cessation of estrogen, which is brutal, especially if you're young. So those people do require estrogen replacement for sure to go through that transition. So we'll talk a little bit about estrogen and hormone replacement stuff, but that's a good question. So there is what we call surgical menopause, where people have a hysterectomy and the ovaries are taken out, and that is an abrupt. And that's, I mean, you think like, 10 years is a long time, but going through that change suddenly from young and fully functioning ovaries to taking it away is hard. So good question. Anything else here? We're going to get to postmenopause, which has some of this stuff in it too. So I feel like I'm doing a lecture. Are y'all asking all the questions you want to do? Because okay, I don't want this to be a snooze fest.
But if your ovaries have been hysterectomy and your ovaries were left in, then you still just go through the regular. When your period really
you don't even know. So in that case, yeah, you won't have a period. So in that case, you might have hot flashes. You might have some of these other, vaginal dryness, some of these other symptoms. But in that case, it might be helpful to like get blood work done and see where your levels are. And it's still important, even though you don't have a uterus, to go in. In fact, it's more important probably to go in for your pelvic exams, just so they can feel your ovaries and check on how things are, because you might not, manifest other symptoms. So good point. Okay, postmenopause. Y'all ready? Okay, so this is the window of time, after menopause. So after you've stopped having your periods. And this is super important because we tend to think as just like our female health and kind of put the other stuff on the wayside. So just keep in mind other disease processes in your body are just more prevalent after menopause. Heart disease, diabetes, cholesterol stuff, sleep apnea. Obviously we've had weight changes that happen that contribute to all this, but also just age in general. Osteoporosis, which is our bone loss in bone density, is a real problem. Y'all, like, we're already past the time of building up our bones. I hate to say it. I'm in there too. We should have been doing that all up into our 20s. So now's the time to continue taking the calcium and vitamin D, because we're just on a decline now for our bones. So lots of walking and strength training helps, but make sure you're taking calcium and vitamin D to help with that. But screening for osteoporosis is important during this window, like DEXA scans. And that's something that your like gynecologist would order every few years, according to what you've got as your family history. Symptoms we see in this time are pretty similar to the menopause ones. Just a lot of the vaginal dryness, stuff like that. Social isolation, isn't that so sad? Like we just get to where we just our home bodies. Okay, so it's so important to talk about these things. Talk about it with your friends. Talk about it with your physician. But they are so impactful on our quality of life. They impact people's mood. Depression and stuff like that is just so significant. There's a whole nother thing on mental health here. I hope it was really good. I didn't get to hear it, but I'm sure it was great. But it's so important on how these symptoms can impact our mental health and everything. So talking through things with your friends, with your family, with your physician is just so important. And like I told you before, everyone's experience is so different. Or maybe I said the class before. Everyone's experience is so different. So you can sit and talk to your girlfriends and don't think it's going to be the same for you. I mean, you just like have to write it out because it's just totally different for everybody. But it's important that we normalize talking about it and how it's impacting our life. And we can do that in respectful ways, but it's super important to like bring these issues up so that it's not just something that we're uncomfortable. I'm an OBGYN, so I'm bold and I'm brazen and I talk about everything. So there's nothing off the table for me. It's going to lunch with me is always fun. So, but it's okay to talk about these things and how it's impacting your life. And in fact, it can help, like getting tips and pointers from our friends that are going through the same thing can be really helpful. Yeah.
So I'm worried about taking something at this point for osteoporosis. They all have side effects. How
So
do you find the right one?
do you have osteoporosis?
Yeah, the last time it was osteopenia, and
Okay.
because I went to another
Yes.
place, now it's a osteoporosis. And the doctor, my PCP regular doctor, wants me to think about taking some kind of pills to
Like
prevent
Bongesta
the
and
bone
stuff
from
like that.
collapsing.
Yeah. So unfortunately, the medications that we have, once you're in the category of already having weak bones, are pretty harsh. They all have like harsh gastrointestinal like side effects and things like that. Um, I can't think of any off the top of my head. Once you're already in the category of osteoporosis that don't have like some significant like side effects.
Right.
So
So you either stay without them or have the side
at the
effects.
very least, you should definitely take the calcium and vitamin D because those, like the side effects with those are just minimal. And so at the very least, take that. But once your bone, and it just depends on where you're at on the bone density. If you're like really like if you've got pretty significant osteoporosis, I mean, you just have to kind of weigh the risks and benefits.
Can you write down or tell me what is I have the results at home. So what is the normal or not too bad
It depends.
osteoporosis?
There's different
there
scores. Like
numbers?
there's T score, Z score. Talk to me after.
Okay, sure.
Talk to me after, and we can go through some of that. Yeah, Sarah.
Estrogen supplements?
Good. Here we go. Here we go. All right.
Transition.
Okay. All right. So here we're going to talk about some of the symptoms and stuff. So if the periods are irregular in that window leading up, like I told you before, sometimes we just cycle regulate with like birth control pills. As far as symptoms, there's a wide variety of things. So if like hot flashes, vaginal dryness are some of your main symptoms, hormone replacement therapy is the most effective. It's generally safe. There was a study that came out, the Women's Health Initiative, years and years ago that scared everyone away from it with breast cancer. There was a bunch of factors that played into that. So generally speaking, hormones do increase your risk of like blood clot and stroke. We live in a society, in a population based on our faith where we're not smokers, so we've got that going for us. But generally speaking, they're safe. Now, I'm just saying that generally because you should definitely discuss it with your provider. But hormones are not as scary as people thought, 15, 20 years ago. There were some studies that scared people away, but we do see some preventative and some very beneficial effects from hormone replacement therapy. So I do recommend hormones. Yes. Your OBGYN is the best place to start. And there's a lot in Bernie, in San Antonio. There's a lot of different really, really great ones. I would try to find one. I mean, in your phase of life, there's definitely in the OBGYN world, there's some that are much more comfortable in the perimenopause and the menopause space. And some are much more comfortable dealing with in and out everyday women having babies. So I definitely would find one that is willing to take the time and energy that it takes, because menopause is a harder one to because it's just so different and a huge variety. So, but your OBGYN for sure.
There's a
Jen.
website that you can put in and it'll tell you if it's a menopause certified OB provider.
I will tell you, having gone through med school residency.
I'll send it out to everyone. If you get your emails,
yes,
you'll get it. I'll send it.
Yeah, having gone through what I would consider pretty significant training in the women's health issues, in my opinion, the menopausal training education is lacking compared to the rest of it. Just considering how impactful it is, and that phase of life is probably the longest phase of life for all of us. You know what I mean? So I would say that you're going to find providers that just aren't as well educated, if I can say that nicely.
I had an interesting experience that my general practitioner is the one who I see forever. I went to him before I needed anything, built that relationship. He caught my thyroid stuff before I ever had any symptoms. And he also gave me a hormone replacement that was non-invasive. Now I don't swallow it, anything like that. Helped me. I keep up my energy. I also exercise and all that.
Mm-hmm.
But then I went to my OBGYN, and he just wanted to know I was taking. When I hit 60, he told me I shouldn't be on my hormones anymore. And I had heard, from my general practitioner all the debunked stuff that they don't believe that anymore. And I said, where do you get that? And he
Women's Health Initiative.
And it was, no, you can't get into that journal. Blah, 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 blah. So I ignored him basically because even though he's my OBGYN, I didn't feel like he was up. And when I went to my regular practitioner, I said, how long do I need to stay on hormones? He said, how long do you want to feel good?
Okay.
And
So
I'm
you're going to.
School teacher and I need energy.
Yeah, you're like, I need it.
I was like,
You're going to see the whole scale. First of all, great. There are, you don't only have to go to your OBGYN. If you do see a family practice, I think Becca has a good family practice that kind of manages hormonal stuff as well. So if you have one that's comfortable in that realm, a general practitioner, a family practice medication physician, internal medicine physician can manage this stuff adequately as well. Some of them don't feel comfortable. But there is a subset that is still in this old mindset of, hormones, we've got to limit it to 5 years. At age 60 or 65, you got to get off of it. And I'm in the realm where that was kind of debunked. And the thing is, like, everyone's different with their continuing medical education. And some people, like, stick away and they just, but that's the hard thing is, like, you always have to learn. Just like the gospel, we're learning every day. It just never stops. So you just have to keep learning and growing. But in my experience and in my personal, whatever opinion, I think it's fine to stay on it. Yeah.
Question. I was actually talking to several ladies about the hormone replacement, and I have one of my friends who's been going to a special pharmacy, and it's like a compound or something.
Compounded pharmacy.
But the doctor sends certain amounts, and they make the medication for you. And I know my OBGYN just when I said hormone replacement, great, here's the pill. And I'm like, no. I looked at the side effects, I'm like, no. And that was the first time I saw her, and it might be the last. But because I didn't feel like she wanted to work with me. And I'm shopping for a new doctor too, so if you have it, please help. Because the doctor I have was great when I was premenopausal, and now that I'm postmenopausal and all the issues are coming,
yeah, see, that's where I feel like there's a big, I think there's a big, I think what you experienced there is not rare. There's like I said, a lot of OBGYN physicians just aren't as well-rounded or as open-minded about the alternative therapies and things like that, which can be very important. And I think in this day and age, people are gravitating more towards natural supplements. As long as the compounded medication, if they're compounding it on an appropriate thing for you, like one thing I will tell you, for example, if you have a uterus in place, you have not had a hysterectomy, and you're getting a compounded or a prescription hormone replacement, you cannot just be on an estrogen only. It has to have a progesterone component to protect your uterus. Otherwise, so that's the only really negative thing that I've come across in my personal medication is people that have been on just a different concoction to where they were just on estrogen and then their uterus was just getting hit with all this estrogen and building up. And I did see some people develop some overgrowth and even cancer in the uterus because of that. That is rare. Just make sure, I'm just telling everyone, whatever compound you're on, if you have a uterus in place, you need the progesterone part of it to go with it. Some people add some testosterone supplementation that is helpful with energy, with libido, and all that I would say is a newer thing. I mean, 20 years ago when I started doing this, we weren't giving testosterone routinely to women. We just weren't ever. And so all of the hormone replacement realm has kind of like evolved, I would say.
But isn't the testosterone something that we keep and that makes us turn into a nice bearded man?
You can. We all have testosterone. We all have male hormone in our system at different levels.
The other two were at 0.
Yeah. So sometimes but some people have like no testosterone, And so it's just a wide variety. So some of those places, they're checking your hormones like specifically is what she's referring to, and then kind of tailoring a compounded recommendation just for you. So, oh, thanks, Jen. Is that your site?
Yep.
Nice. Okay, so that's a good question. And then, there are some natural remedies. All these things you've probably heard of, sage, black cohosh, red clover, can help with some of these symptoms. In the research studies, which they're not like powered by all this financial support that some of the big pharmaceutical studies have, they don't usually show the same effectiveness as medications. But also, like I said, the research is probably lacking in some of them, but they're just maybe not as effective, but they're definitely not harmful. So there's a wide variety of, thanks, Jen, of natural supplementations available as well. Okay, I can't remember what else I have on here, y'all. We talked about bone health, heart health. Believe it or not, from all these things, heart health, like that's the number one killer of women, definitely your heart. So don't ignore that. That's not in my realm, but it's important to do that. Okay, so I listed like a bunch of problems. Does anyone have any like troubleshooting, women's health troubleshooting questions they have for me? Leaking urine, prolapse, abnormal bleeding. I will tell you this. Let me bear my testimony of Relief Society women's health issues. Back when I was young and in my private practice days in Arizona, I did a thing very similar to this for my sweet Relief Society there. And my Relief Society president came up to me afterwards and she said, I'm having a little spotting. Any bleeding after menopause is abnormal and needs to be evaluated. It can just be that your vagina is dry, but it can also be cancer. But I say, if you have any bleeding after menopause, I'm bearing my testimony. Go see your gynecologist. Anyway, this sweet sister came up to me and said, like, I'm bleeding. Anyway, she came and saw me. She did have endometrial cancer. She just emailed me like a year ago, like, I just wanted you to know I'm doing fine. And I just love her. But anyway, I'm so glad I talked to her. She didn't think anything of it. It was just something she had been ignoring. But I will tell you, any bleeding after menopause needs to be evaluated, period. If it's spotting or anything, it just needs to be checked out. There's a wide variety of things we run into, like our bladders dropping, our uteruses dropping, that are things. So I just like listed a bunch of stuff and figured we could talk about whatever. Yeah, Sarah. Although we have like 5 minutes now.
What can you do about some of this stuff, like leaking urine or the vaginal?
Okay, so leaking urine, it can be from a variety of things. It can be from an overactive bladder, which that's medication that kind of calms the stimulation of the bladder. But it usually, in our case, is we've had pregnancies, we've had children, they've destroyed our pelvic floor and everything that's supporting everything. So usually it has to do with that. So most of these, as far as leaking urine, but let me say, that being said, if you are leaking urine, you should go in and probably be seen by a urogynecologist, which is a OBGYN that specializes in the urine side of things, for some specialized testing to get to the root of why you're having it. But most of the prolapse, which is like the dropped bladder, dropped uterus, and the leaking urine, mostly they're fixed surgically. So they're usually minor like procedures like slings and tightening up some of the walls in the uterus, but it also is more significant things like elevating the uterus and like supporting the ligaments, which is done inside like laparoscopically. So mostly, unfortunately, there are things like pessaries, like inserts that you could put in to hold everything in, but then you're like inserting like a item into the vagina to hold everything up, which gets cumbersome. So mostly these things are fixed surgically. And we just thank heavens that we have our little babies that destroyed them. But yeah, there's not a great way to prevent other than the normal things you've learned, Kegels and stuff like that. But unfortunately, everybody's body is just so different as far as like our tissue and how things. So you're going to have one woman that just everything is dropped and really low, and someone else that's really well supported. I will say smoking destroys the tissue down there, and luckily we don't have smokers in here, so that's something we have going for us. The slide before this. Let me see. This one?
Oh, okay.
Okay. I can't remember what else I have. Oh yeah, that's probably it. So any other questions about this stuff? Yes. It does. So there's some pelvic floor therapy both with devices and with like a physical therapist exercising that can help. And then like sometimes they have more intricate devices of like, okay, I'm going to put this here, you're going to squeeze here to work those muscles. We have seen like pretty good effects with some of that. So it can be very, very helpful.